This is prognosis from an evidence-based practice standpoint. This is the hierarchy of evidence from the Center for Evidence-Based Medicine. We have levels varying from 1 to 5, and if we ignore the systematic reviews, we see that a 1B is something called an individual inception cohort study with 80% follow-up. We're going to contrast that with a case series study. But before we do that, we'd like to understand the motivations for ranking these studies as high or low. And to start off with, let's understand how the study design, the 1B study design that we're interested in, parallels or complements our clinical experience and how we make decisions about our patients. So essentially, if we think of ourselves as an analytical person that's looking at our patient at the beginning of their disease process, one of the first things patients are interested in is how they're going to turn out or after the disease has run its course. And we're also interested as a therapist in which tests and measures we should use to make these predictions about our patients and their outcome. And so what this represents is a person here who's looking at evaluating a patient and their ability to track or take all kinds of numerical readings from the patient. And that's what the whiteboard represents, and then how they should use those to make a prediction of an outcome that's important to the patient. And this single outcome could be something like return to work, return to sports activities for a younger person, the ability to return home after a hip fracture, or whether they'll be assigned to a nursing home. These are important clinical outcomes for our patients, and they expect us to make some kind of reasonable prediction about their ability to succeed or not based on variables that we take into account at their baseline point or at any common point in their rehabilitation process. And so this is the basic design of a study where we're going to look at a variety of variables at a specific point in time, either the start of their disease or another point in the disease process, and then try to see how well those numerical values actually predict an outcome. Usually the outcome is dichotomous, meaning they either did or did not return to work, or they did or did not return to play, or they went to a nursing home, or they returned to their previous living situation. So those would be examples of dichotomous outcomes. So that's the basic structure of a prognostic study, and note that it parallels our clinical decision making. It's also interesting to note that the diagnosis and prognosis share a lot of similarities. And the first thing is we evaluate diagnosis on its accuracy, or the ability of the test or measure that we're using to accurately predict the presence or absence of the disease. So notice that in prognosis, we're also using tests, only now the tests are being used to predict a specific outcome that's also dichotomous. And so we're interested in very similar types of statistical processes. So we're interested in evaluating accuracy. It's very, very much like we were interested in evaluating accuracy for diagnostic studies. So we expect, in the best sense, to see statistical analyses that include our receiver-operator curves, or specificity, sensitivity, likelihood ratios, or something like that. Now, what's different is that in diagnostic studies, we're just very interested in the diagnostic or test's ability to reflect a physiologic disease inside the person. Where in prognosis, we're not really concerned with just the disease process. We'd like to know about a variety of different outcomes, including activity limitations on the ICF model, participation kind of level, which it was things like a return to work or not return to work. And then any number of predictor variables could be used rather than just a single test or measure that reflects a diagnosis. So this is a good example of both disease-specific measures like the stage or severity of a problem, And we're interested in these other factors like demographic, comorbidities, and biobehavioral factors because they potentially could modulate the disease process. A good example is age. An older person we expect to have slower recovery with many diseases, where younger people a faster recovery. Or something like a depression, where they're more able, an undepressed person is more able to actively participate in their care and advocate for themselves, and where a depressed person may have difficulty complying with something like an exercise program or asking appropriate questions at follow-up. And those things may cause the disease to be delayed. So essentially, prognosis asks about our ability to predict not just specific to disease-specific variables, but also other peripheral variables that may modulate the progress of the disease. So let's start our exploration of this by understanding what the difference between a high and a low study is on this hierarchy. So we see there this inception cohort study with an 80% follow-up. That's going to be our 1B. And then a case series is our low-level study. So let's contrast those two and understand how those reflect why that's one's considered a high level of evidence and the other's considered a low level of evidence. So we'll use a case example to motivate this explanation. So let's say we have a 23-year-old athlete that experienced a non-contact ACL rupture 4 weeks ago. After 4 weeks, her swelling has gone down. She has no pain at this point. Her range of motion is near normal, but she still has a strength deficits that's significant, about approximately 50% on isometric testing. Her goal is to return to high-level competitive soccer. Here's her questions. She's feeling awfully good right now and is wondering if she really needs surgery. What's the benefit to her of having the surgery or not? Irrespective of what treatment she gets, what's her likely return to sport? If she tries to return to sport, will she return at the same performance as she had before? And then if she does, given her particular case, what's her expected return? Can she do things to accelerate her return, or are there indicators during her rehab that would suggest she can return earlier or later than usual? Now, she has questions, but you also are likely to have questions too as the therapist. You have choices of tests and measures to use. You can give her different types of advice. You can encourage her strongly or leave the decision completely open to her based on the data that you have in terms of educating her about different outcomes. So the first would be this question about surgery. What's her risk of re-injury? What's her best probability return to play with or without surgery? And then also, just in terms of her, what's the significance of her strength deficit and predicting a shorter or longer rehab? She has a 50% strength deficit. That seems fairly significant. Does that mean she has less chance of returning early to play, or does it not matter? What's the significance of a high or low strength value at the beginning of her rehab? And at what point should you expect her knee extension strength to reach above 80% or return to approximate values equivalent to the uninvolved side? Here, this is critical. If you are anticipating an early return to extension strength, you might inadvertently be pushing her when you should be more patient. And likewise, if you're anticipating a late return and you should be expecting an earlier one, you would not be pushing her hard enough. And so knowing just what a global benchmark is for when most people return would be useful to you. And then finally, does restoring normal strength assure her successful return to play? At what level do people with minor, like 10, 15% deficits versus people who are completely even for return to play? How much of a factor is that in determining their successful return to play? So given those types of questions that either you or your patient have, you might conduct a search. And so essentially the way that the PICO would work is the patient would be an ACL rupture. The intervention is yes on prognostic studies. Control would be the no on the prognostic factor. And then the outcome would be return to play in this case. Now, you could make it simpler and just say, well, we'll search on the patient and then the prognostic factor and then whatever outcome you're interested in. And you could also add words like prognosis, prediction, or cohort design to enhance your yield on the search. So given that search strategy for ACL ruptures, we yielded these particular studies and noticed that this one emphasizes the prospective nature of the trial, and that's going to be a higher level. And these other two substitute the word predict for prognosis. And so this second one is predicting function. Function is, this is the IKDC 2000 is a self-report, a scale of function, and then quadriceps strength. So it's looking for the ability of quadriceps strength preoperatively to predict a 6-month functional score. So this directly answers our question relevant to the importance of preoperative strength values and what their patient's expectations should be. So this is the kind of study you're looking for with prognosis. So now let's contrast a high and a low level study to understand the difference between the two. Let's start with a low level study. So this is a case series. It's a typical pre-test, post-test, single-arm design. And so we'll start by looking here at some of the results. So this is approximately 20 participants that were tested preoperatively and then at various follow-up points up to 28 weeks. This first variable is their the SF-12 physical component scale. This number C is the activities limitation scale, the International Knee Documentation Classification Scale. And then the B value scale here is their maximum isometric knee extension force at 45 degrees. So we can see here is that the 0 is the surgery, and then the preoperative point, they all, on all three scales, health-related quality of life, function, and knee extension strength, they all decrease their abilities immediately after surgery. Now, if we can also see, notice a couple things, that the 60 on the SF-12 is the high score. We can notice at 28 weeks, in terms of self-report, the health-related quality of life doesn't return to the top level of the scale, which is surprising for a young athlete. And similarly, the best they could do on the functional scale is around 80% at 28 weeks. So it points out to us that if we interact with our patients, it shouldn't surprise us if they're typical. They'll still recognize deficits in their health-related quality of life at 28 weeks and their ability to kind of reflect their pivoting and running and landing mechanics. They'll still note limitations on self-report at 28 weeks. That would be a typical response of patients based on this case series data. Now, if we look back here at our question, our therapist perspective on goals, setting goals, and managing expectations of our patients using prognosis, we notice here that there's in terms of knee extension strength, there's a marked decline initially, and then there's gradual improvement. But also notice that if, according to this sample, we shouldn't really expect full return of recovery until 28 weeks. There was no statistical significance between the preoperative values and the postoperative values until 28 weeks, where they return to near normal or symmetrical uninvolved strength to the involved side. And so what this suggests to us is we should be patient in terms of setting goals and managing expectations associated with strength with our patients. Now, notice what this doesn't do is it doesn't allow us to make an individual prediction on whether our particular patient would have a delayed recovery or not because of her marked strength deficit. She has an approximate 50% side-to-side difference of her involved side, which is very atypical given this data for a preoperative value. And so it's unclear to us if we should modulate her recovery expectations lower. For example, maybe it would take 32 weeks for her to get her strength back because she's starting at such a low level. So this is one characteristic of a case series design. It allows us to look at typical values and typical recovery of patients, but doesn't give us much information about individual responses that are unique to a patient. So it doesn't help us understand how to adapt our expectations or manage the expectations of the patient based on her particular strength value. Contrast that case series study, which is considered low level, with one of these high-level studies, either an inception cohort study or a retrospective cohort study. I've selected a retrospective cohort study to illustrate this contrast. So let's examine this retrospective cohort design where done by Dr. Hurd, and she evaluated 10 years of data from a single physician's office, and they looked at all participants that had gone through this screening examination for returning to play without surgery, and were able to follow all of them but a few patients over that 10-year period, which is pretty impressive. Essentially, they had an algorithm for admitting people into a exercise program before they returned to play. Part of that algorithm was this screening exam. So in this particular study, this would be the prognostic set of factors that are being used to tailor the individual treatment to that particular person, and then looking at the outcome over that 10-year period. And so we can see here is that the battery of tests included a unilateral hop test, where they were required to have greater than 80% hopping ability from one side to the other, and to qualify for the non-operative program. And they also had a self-report score of greater than 80%, a global rating of greater than 60%, and less than one giving way episode up to this point of their post-injury experience. So we can see if they fit all of this criteria, then it was their choice of whether they wanted to opt into the non-operative program, complete the agility training with no episodes of giving way, and if they were able to complete that and then qualify for their sporting event, they were cleared for a return to sport. So of the 63 individuals who went through that process after a approximately 10-year follow-up, what we can see is that 25 of them still had not had ACL reconstruction, where 36 had, and 2 were lost to follow-up. And so essentially what this suggests to us is that they can safely return to sport. However, less than 50% of them will continue to play without an ACL reconstruction. The majority will have, approximately half will have choose to have the ACL reconstruction ultimately. So in terms of answering our patient's question, we could say if they were very, very committed to not having a surgery, we could then apply this classification criteria and unique to them make a clinical decision that they could adequately or safely return to sport, given that the rehabilitation process went well. They would have approximately a slightly less than a 50% chance of continuing to play without having surgery. So given this outcome, it's likely that most patients will choose to have the surgery, given there's only a small chance of success otherwise. So this answers our question, and allows us to make a decision that's unique to an individual rather than describing typical responses over time. So this is a trait of high-level studies, and what we're going to notice as we go through the critique of 1B or inception cohort studies is that the idea is to try to drive the clinical decision making to the point where we can make really accurate predictions about outcome about an individual patient. And that's the reason for classifying an inception cohort study design with low attrition as the 1B level and the highest on the hierarchy.